Welcome to the TelePT Connections Podcast. Physical therapy information, innovation, and insights for patients and providers. Physical therapists and innovators Dan Seidler and Adrian Miranda will help you connect with your neuromusculoskeletal system, discussing how to care for every physical ailment they've ever seen or heard of, the latest digital health technology, and other fun stuff from their PT toolbox. Great guests, 21st century home remedies, exercise thumbs up or thumbs down. Now, here are your hosts, Dan and Adrian.
Hey, you are on the air. I'm Dan Seidler, and this is my co-host, Adrian Miranda, here on the TelePT Connections Podcast. Coming off a controversial week, a lot of scandalous activities going on here at the TelePT Connections Podcast. We recorded a session, and the guest wasn't so happy with some of the things he said. Maybe
things were said, regrets were had. Things that we didn't think it was regretful, but you got to be cautious with that.
Very cautious, and I want to be sensitive to his feelings and his thoughts. I thought it was a pretty good episode, but
that's right.
No one's ever going to find out about it.
And we're respectful here on TelePT Connections.
Exactly. Yesterday, I also got an email from a previous guest who was concerned about video. We had put some video up, and he wasn't sure that maybe it would also possibly incriminate him, or he did some things, or I don't know. But then he reconsidered, and he was like, you know what, just leave it up. And fact is, we have very few hits on our videos. We kind of just use them for promotional purposes. And but you can check them out. Check out the YouTube page. The YouTube page is actually Daniel Seidler for now. They're on my YouTube page. We have some clips, and I use them on Twitter and LinkedIn to promote the show a little bit. But what's going on with you?
Not much. I'm working. I more want to hear about you. I want to hear the updates about telehealth, the state of telehealth, because you are part of an international or national telehealth, American Telehealth Association.
Well,
committee, right?
I'm a member of the American Telehealth Association, and I participate in a couple of the special interest groups. One of them being, I think what you're referring to, is the Interstate Special Interest Group of the American Telemedicine Association. We actually had a meeting this week. I don't know if you knew that or not, but there was a meeting this week. And we got some really good updates from this guy named Evan Hoffman. I'm not sure exactly what his role is, but he presented to the group. He'd been doing, I think he's an outside consultant, and he's done some research recently on policy changes and new laws that have gone into effect in a bunch of states. And there's a lot of things rolling out. I mean, the big one always is CMS and Medicare. Like we want, in order to really push reimbursement and policy forward, it most importantly should come from the federal government, and states often follow the way. But some states are out on their own, making laws that are very positive for telehealth. The one question I asked at the end of all of this was, all of these laws that are going into effect that are going to extend telehealth, the ability for practitioners to practice via telehealth and get paid for it by payers. I asked the question, do these laws apply to all services? Is it just medical? Is it ancillary services? Is it PTOT speech, which is our world? And he couldn't really answer that question. Some states are. Texas has a new law, and that definitely includes PTOT speech. Others, it's kind of unclear, though. But states like Maryland, Virginia, Kentucky, Tennessee, state of Washington, state of New York have all enacted telehealth access laws, essentially, which will improve access to telehealth, improve the ability for patients to see their practitioners or their doctors via telehealth.
I'm going to interrupt you for a second.
Yeah.
Did you have those states memorized, or were you
I took notes.
What are the odds that you have it in front of you at this moment?
Well, I'll say this. I wasn't prepared for the question. I didn't know you were going to ask me the question, but it is kind of coincidental that I did attend a meeting this week. I took notes. And my notepad's right in front of me. It always is.
That's wonderful.
It always is. So thank you.
I was like, is he off the
Thanks
top
for
of
props.
his head?
I feel like a professional. Sometimes,
Either
sometimes
way,
I'm
it's
just
impressive.
winging it, but thank you.
I was like, he's prepared for this.
No,
He had no idea what I was going to ask him.
I didn't know that was coming, but
okay. So this is all about Medicare, though, right?
It's not all about Medicare. No, this is about
Texas. Tell me more. Give me that. Recoup what you just said about Texas.
Sure.
What does that law stipulate?
Yeah. I believe, and I don't know the specifics of the Texas law. I'm not that prepared, but I believe it requires Medicaid, Texas Medicaid, and commercial payers in Texas to cover telehealth services in the same way that they would in-office services. Now, it should be understood that coverage is different than payment parity. So there's coverage parity and payment parity. Coverage parity just means like they're required to cover it, but not necessarily pay at the same rate, meaning that the rate might be a lower set rate, or it can be a rate that's negotiable between the payer and the provider.
Yeah, I feel like that's a really important note, aspects to have, because I think it's like you're covered, but it's like you're going to get reimbursed $10.
Yeah, exactly.
Versus you're covered and you have parity, you're going to get paid $70.
Right.
So I think that's when we first started talking last year, being a pandemic, I didn't know that there was those two differences, and I think that's something that has to be fought for moving forward. And so, what about New York? Where are we?
So just to finish that last thought, people in the meeting, in that ATA interstate meeting, he gave his presentation, and he didn't really make it clear. He said parity, and there were most of the people in the meeting who are like well versed in telehealth policy and law, didn't all know the difference between coverage parity and payment parity. Now they do. I think it got clarified in the meeting, but to your point, it's really important, and the ATA is really pushing for this, that payment parity is happening, not just coverage parity, but payment parity, so that practitioners who practice via telehealth, whether it's all their visits or some of their visits, some of their care, is being covered at the same rate as in office.
New York State. Go.
New York State. So the New York State budget was enacted last week, April 19th. And one big thing that New York State did was it removed the restrictions for originating site and distant site, meaning that there were some laws in place that said a patient in New York needed to be at a doctor's office or in a hospital or at a school or some sort of facility in order to receive services via telehealth, which is pretty silly in our mind, right? But that was a regulation. This is like pre-pandemic. Everything during the pandemic, during the public health emergency, it's been all fair game. So that's why everyone's been able to practice, do their telehealth, and get paid for it, and it's all been fine and good. We're talking about laws that are for beyond the public health emergency. So now, as of now, in New York State, a physical therapist can see a patient who is in their home or at their office legally, basically via telehealth. And the PT also can be, there were restrictions on where the PT needed to be also. The PT was required to be in an office prior to this law going into effect. So now the PT can practice from home, patient can be home. That's what we've been doing during the public health emergency, but that would not have been legal if the previous law was not waived. Now it's legal going forward.
Okay.
So now you can practice telehealth in New York State and you can smoke marijuana.
That's all we need. We can move forward.
There you go.
New York City has been rebuilt officially.
That's right. Well, in New York State, in the past couple of weeks, marijuana has become legalized. It's legal to smoke in public. Can't sell it by retail yet, just in a store. But that's I think that goes into effect as of next year. I have a question for you.
Okay.
What are your thoughts about medical marijuana as it applies to what we do?
Oh, I have no thoughts, to be perfectly honest with you. I think I don't know enough. I grew up around it, surrounded by it.
Mm-hmm.
But I can't imagine why it wouldn't be medicinal. I can't imagine. I mean, I have anecdotal. I'm sure there's even research evidence. I don't even have to say anecdotal. Patients who say it worked for them, for the knee pain, for cancer treatments, for a number of things. I used to have patients ask me like, "Hey, what do you think? Should I try?" One patient was like, "Hey, Adrian, I know I'm 75, but I'm going to sound like a hippie. What do you think of CBD and cannabis and marijuana?"
Yeah, right.
I was like, "Whatever you want. You're 75. You can do whatever you want."
Exactly.
And she's like, "Oh," she starts laughing. She's like, "Oh, I feel so strange, but I want to try it." I'm like, "Listen, I can't tell you to do it or not, but there's plenty of evidence out there that it does, have positive benefits."
Sure.
But I think like with anything,
and psycho, not necessarily. Sorry, not the psycho, somatic, but not the psychoactive parts of it, but more just the pain relief, analgesic effect.
yeah, I mean, I think like with anything, you overuse it, not going to be good. If you use it right, it's going to be wonderful. You can exercise and then you can over exercise. And so I really have very little to say about medical marijuana or marijuana recreationally.
Did you ever treat a patient who had gotten high before a visit?
Yeah.
And when I say get high, I mean like smoke a little, take a puff.
Yes. I've had patients come in slightly drunk, tipsy,
blazing high.
Slightly high, slightly tipsy, tipsy, slightly drunk, hungover. Yeah, I've had it all. And none of those are bad experiences at all. Like people were completely functional and kind and nice, and they were a little bit silly, but nobody was rude or belligerent or angry at all. If anything, they were more calm. They got more out of it if I was doing manual therapy. But I've seen a lot.
I mean, I've had many patients, and the first one I experienced, I remember this was like one of my first years in my own practice, and this guy's come in, and you could smell it on him, and he was high. He was just like, he was chill. He was, and I talked to him about it, and I was like, "You smoke before you come in, don't you?" And he said, "Yeah, man, I need to because I need it to put my head in the right place." And it calms my body too. Mm-hmm. And I was like, I think the fact that you're preparing yourself for therapy in your head and your body, and you want to be in it more, I'm cool with that. I mean, he wasn't, like you said, it was never a negative experience. He definitely was in control, and he was a great patient.
I mean, I've had patients also reek of cigarette smoke, like reek. So, we got that extreme as well.
Yeah.
But yeah, I don't, to answer your question, I don't really have any strong opinions either or. Sure. If it helps, that's on them. Yeah. But I can pull out research probably to back things up.
Yeah. And the reason why I ask is because I think it's just going to be more and more prevalent in our space. I think more and more patients are going to utilize.
Pre-medicate? They're going to pre-medicate.
Yeah.
It's like maybe the replacements come in.
Maybe not necessarily for treatments, but as part of their recovery. They might go, and I'm sure it's happening in other states already. CBD is being pushed all over the place in the pain management and pain space, whether it's creams or pills, whatever else, CBD. Mm-hmm. And it definitely has same sort of effects. Not the psychoactive effects, but maybe the anti-inflammatory. I don't know where the science is on it, to be honest with you.
Right.
But it definitely there's definitely something there, and I think we're going to see a lot more of it as that becomes sort of maybe the new medication in a lot of ways. Particularly as there's all the pushback against opioids. Certainly a safer alternative.
The safer alternative.
Yeah. Did you have any other policy questions for me?
I have a ton, but you totally segued to marijuana. You had that on your mind all morning, didn't you?
I like talking about marijuana.
Apparently, that we're on video, but behind Dan's left shoulder, there are 2 pots of small plants, and I'm not sure what he's growing there. It's probably just from Target, but we don't know after that question.
You forgot to mention the 3-foot bong that's off screen too.
Oh yeah, exactly. That's not a candle; it's a bong, is it? Right. Dan is from Long Island, after all.
Does Long Island have a reputation for being a haven for weed?
not a haven, but I mean,
Okay.
there's
'Cause I also
money
went-
out there. So one of my
Well,
high school friends,
I also went to the University of Vermont, and Groovy UV definitely has
groovy UV.
its
All right, that makes
reputation.
sense now.
There you go.
But all right, yes.
We had some fun.
So okay, so you're having your ATA. It's called ATA, right? That stands for American
Telemedicine Association.
Okay. What is on the agenda? Like, what are you all trying to push for? Like a national telehealth, telemedicine appropriations bill or something like that, or like what are the conversations being had? And now,
right. Good question. I mean, there's a lot of, and the ATA basically reorganized in the past year and a half or two. They had started. There's a new chairman came in, and they started reorganizing and really getting their ducks in a row, starting like January of last year, 2020, and obviously it coincided with the pandemic and telehealth taking off. So things have been gradually evolving within the organization, and they really like seem to be, and I'm not very active in it. I've just been a member for like a year and a half. I shouldn't say that. 2 years. I just renewed, so it's been over 2 years. But it's right now it's about like setting the priorities. So what are the priorities in the telehealth policy space? One is definitely federal. So pushing for federal laws that enable telehealth to continue, practitioners to continue to treat via telehealth and get paid for it. And federal laws meaning payment by CMS, essentially, which is Medicare. So it all goes back. The federal stuff all goes back to Medicare. And then similar things happening on the state level. So there's every state makes their own laws for Medicaid and commercial care that happens in their state, in addition to licensing regulations, right? So New York State, for example, as a physical therapist, we follow the rules of the education department for physical therapy, right? The PT Practice Act is under the New York State Education Department. So the laws, first of all, have to say that PTs are allowed to practice telehealth. New York State law definitely says that. Then policy on the level of policy has to go into effect that says Medicaid is required. New York Medicaid is required to pay to cover telehealth physical therapy and pay at the same rate. There's your payment parity for Medicaid. And then we want the same thing for payment parity for commercial insurance, commercial payers. Okay. So every state operates on their own.
So quick question though, like the states for commercial, can the state, and I actually like met with a legislator in Brooklyn, can the state mandate or require a commercial payer to pay a certain rate? Does that happen anywhere?
No.
Any other state?
They don't have to pay a certain rate, but they can say, for the example of telehealth, they can say that they're required to pay at the same rate as if a patient was seen in office. They can do that. So that's payment parity. They cannot. I don't believe that the state can require United Healthcare to pay $80 a visit for physical therapy in New York. I don't think they can do that. It's a competitive market. They can set their own reimbursement. It's a contract. It's a business to business contract, essentially, sort of, where the insurance company acts as a proxy for their members with the provider.
Sound like exciting conversations y'all are having.
I'm not going to say they're jovial. I'm not going to say that they're the funniest thing that happens in my daily routine, but they're certainly interesting and relevant. And you kind of, before getting involved on this level, I didn't understand how a lot of these things work. And I think it's important as a citizen of this country that you do understand who's pulling the levers and like how they're being pulled, like, where it's all coming from. And the reality is that squeaky wheels get the oil. It is a lot about the money, of course, like an insurance company and their lobbying pushes and all the money that they can push into an agenda certainly is going to have more weight than me and a bunch of other citizens. But shit doesn't happen unless citizens speak up. So and it often is one or two people who get in the ear of a representative, and they're really passionate about it, and the representative becomes passionate about it, and they champion a bill, and they get their other colleagues to get on with it, or to go along with it, and it happens. So that's kind of what's happening in telehealth right now. And as I said during the ATA meeting, if ever there was a time when the iron is hot, this is it. I mean, we got to be pushing now.
Okay, so that's ATA. What about in Dan Seidler's TelePT services? TelePT services. What's it been like? Yeah. So it's been a year since you were consulting, and now you're doing it and consulting.
Yes.
What is your outlook? How's it been? Pros, cons, ups, the highs, lows. Give me the state of the union of Dan Seidler at TelePT services.
It's been, like you said, highs and lows. This time last year, I could not have been busier. I was working 16-hour days, 5 days a week, maybe more, and working through the weekends as well. It was pretty bananas. I was really busy. I hope I helped a lot of practices get their feet wet with telehealth and get their programs off the ground, and hopefully helps them. I mean, from what I hear from them, it helped them get through a really tough time, and some of them have continued to do telehealth in their practice, and mostly all PT practices, a couple of PT, OT, speech. Some of them are continuing to provide the services, and I still work with them, but I spend most of my time these days building a telehealth provider practice. So we're doing PT visits by telehealth, all in New York at the moment. All in New York. All of our patients are in New York, and that company, TelePT Solutions, is the consulting. I don't really do too much of that right now. My practice is TelePT Services, and I'm treating patients essentially on an outpatient basis by telehealth. It's been great. It's been amazing. The things that of note are that our outcomes are excellent. Patients are getting better from telehealth services only, from telehealth PT only, which is, against what a lot of people believed could happen. But patients are getting better. I mean, just as much as they would in office. I haven't seen any difference in the type of progress or outcomes that we're getting. And of course, our attendance and patient satisfaction is even better than in office. It's very rare to get a cancellation. It's very rare. Almost had a cancellation this morning. Patient had to drop a relative off at a doctor visit and was running late. And he just called me up and he's like, I can't make it at 8:30 this morning, but I'll be home at 9. Can we do that? I was like, sure. I'll go downstairs and get another cup of coffee, and I'll see you at 9.
What's your cancellation rate this last month, or last time you ran numbers?
5%. 5%. So 1 in 20.
And so
I was never below, as a private practice owner in the Bronx, we were never consistently below 15%. We had a month or two below 15%, 13, 12 maybe here and there per year. But typically our cancellation / no-show rate was probably between 15 and 20% every year. That's 1 in 5.
Okay, so then
now I'm at 1 in 20.
So like so for people like listening, wanting to telehealth, or they're in telehealth, like how are you tracking outcomes? Like what do you mean? You said the outcomes are
FLR, outcome measures, subjective outcome measures from patients.
Subjective satisfaction or pain or function?
I guess are those considered subjective or objective? I don't even know. So like an Oswestry,
subjective, yeah.
No, like an Oswestry, LEFS, Quick Dash for the uppers. I think it's Oswestry cervical also, and we do other things, so like 30 seconds sit to stand, timed up and go, things like that.
What about the patient satisfaction outcomes?
It's like 99%. I mean, patients love it.
I mean, how do you do it? What I'm asking is like,
good question. I have not done an actual like I forgot what the measure is called. Consumer satisfaction, CS. I can't remember. But no, we haven't actually done that. I mean, if you asked any one of our patients, they would say they love it. It's like consistent. And I follow up with patients who are not mine also. I'll text them once in a while, just say hello, or I'll call and say, how are things going? And I just have not gotten any negative reports yet of how this is working for them. I'll qualify that by saying I have had patients drop off at the beginning. So a patient will be evaluated, we'll give them their plan of care. They'll be like, I'd rather go into an office. Okay. So I guess that's dissatisfaction, right? Or disbelief in the ability of telehealth to actually help them. I certainly have patients call for appointments. Like they'll get our name or number from their doc or from their insurance listing, their insurance company listing. And I'll make it clear to them right off the bat, you do know that all services are by telehealth. We do not have a brick and mortar office. Are you cool with that? And occasionally patients will say, oh, I didn't know that. I'd rather go into an office. I've always gone to an office. I'm going to go to an office. And okay. I guess that's considered dissatisfaction, right? Maybe.
Yeah. No, I think it's, no, I'm just kind of curious about like, how do you track satisfaction? PTs have a tough time with numbers, right? Tracking outcomes that are not just the LEFS and the OSWESTRI.
Sure.
But yeah, I was just kind of curious about what other telehealth providers are doing. How many of you are there?
We need to do patient satisfaction questionnaires, surveys. I just haven't gotten around to doing it yet. We're doing like 20 visits a week right now, which is not a lot, but it's it's a small caseload, and it's growing.
That's you or all your providers and yourself?
All of us together. Well, two and a half of us together. So my other PT is full time. She's not full time. She does 1 day a week. She has a full schedule 1 day a week. And I have a PTA, and I do all the rest of the visits. Other things that we offer are we also outsource our services to white label our services to other practices. So we work with, we have one practice in New York, and we have one practice in Georgia right now, in Augusta, Georgia. Buddy of mine, Rafi Salazar, if any of you guys know him. Great dude, OT, owns a practice in Augusta, and we're just starting up Rafi offers a subscription service to his patients. So a patient has a total knee replacement. They'll come into the office, get an evaluation. A lot of his business is cash, and they'll pay a monthly rate for a certain number of PT visits, in-office visits per week, combined with a certain number of telehealth visits per week. So maybe it's 1-on-1, and they pay, I don't know, $400 a month, something like that. I'm kind of just making up the numbers. I'm not sure what they are. And that patient is entitled to 1 in-office and 1 telehealth. And we also provide support if the patient wants, if they want to text or reach out or have questions, we can do that through a secure network with the patient. And that's all part of their subscription. So we provide that service.
How can you do that in Georgia, being in New York State?
Well, Adrian, I'm glad you asked that question. First of all, if I was licensed in Georgia, I could do that. You just have to be licensed in the state where the patient is. I'm not licensed in Georgia, so I have a PT who is licensed in Georgia who provides all that care. So essentially,
that makes sense.
Yes, and you just have to be licensed in, I am licensed in Florida, and I'm licensed in Utah, so I can treat patients in those states from New York. And our Georgia PT is in the PT Compact. So she can get compact rights to treat in 20 other states in addition to Georgia. She hasn't done that yet. We don't have a need for it yet, but if we have a need, she could do that. Pay $50 per state, I think it is. It's different for every state. Maybe take a jurisprudence test, and she'd be able to treat in Colorado, Iowa, wherever, any of the states where she passed that or paid that fee. Now, what I did learn yesterday is that it's very unlikely. People often ask, how come there's not a national license? It's not going to happen. Not going to happen in probably in our lifetime. It's not going to happen. There's just too many laws that prohibit it. and those laws would have to change in too many places. And that goes from medical across the board, healthcare across the board. States have too much control over licensure to give it up and to allow for that to happen. But compacts are definitely a workaround for that. And there are compacts in PT, OT, nursing. They're working on a speech compact, medical, obviously, PA, you name it. There's about 8 healthcare compacts that are recognized by the ATA.
Wow. So it's been a year since
That's right.
we all were forced to go online. Isn't that crazy?
It's been a year. So yeah, and what it's done is it definitely was a huge kick in the ass for the telehealth industry. And not that we weren't pushing hard before, but the door opened essentially. And it's been a tremendous year in the development of how healthcare is delivered. I think we're never going to turn back. I'm not saying everything's going to be remote, everything's going to be telehealth, because that's not going to happen. I'm not saying that there won't be challenges. There definitely are plenty of roadblocks ahead, but the world has changed already, and it's not going to go backwards. So a lot of care is definitely going to the way you receive and provide healthcare services is never going to be the same way it was before this pandemic. And it's going to continue to change. It's going to continue to evolve. And I think for the better. We definitely have a lot of problems. One major thing that this pandemic has done is it's exposed the cracks in the system, and I'm not the first person to say that. The healthcare system in the United States has major issues. There's great care in some places and horrific care in other places. And that was really exposed, and it continues to be exposed. So there's a lot of really smart people, a lot smarter than me, working on these problems. And I'm involved in my own ways, and we're trying to. I've partnered with my technology partner, I guess, Better PT and Better Access. Those are their brands. Better PT in particular, to form a company called TelaPT, TelaPT. And what we're doing is we're really addressing the problem of falls, particularly in the elderly and people with comorbidities and conditions that make them susceptible to falling and potentially causing major problems for them. Significant cost, $30,000 to $40,000. It's reported for any fall that ends up in a hospitalization. So we're addressing that head on and working with populations of patients that are at risk for fall. So there are affordable care organizations that manage the lives of patients with diabetes or end-stage renal disease, or elderly patients who have Medicare Advantage programs or in Medicare Advantage programs. And we have a falls prevention program where we're screening patients, and then we're providing care and providing falls prevention programming, particularly exercise and other falls prevention initiatives and falls prevention strategies to minimize their risk, each individual's risk for falling. And that's all through this company, TelePT, TelaPT, and it's telept.com. And we're going directly at that market of falls risk. And it's a major problem in this country. I don't know what the exact numbers are, but it's obviously a risk and a problem for the people who fall and their families, but it's also a major problem for the healthcare system in general because it's so costly. And if we can reduce those costs, if you can prevent one fall, that could be $40,000 right there.
Or someone hurting themselves.
Well, I mean, that's most relevant, or dying. I think every PT hears that, like in the first year of PT school, that falls lead to hip fractures, which lead to death. I mean, it's almost like a linear path for a lot of patients.
Falls, fear, dementia, death.
Yeah. I mean, cool. I don't know what the numbers are on that, but a significant, I think like a third of patients who are over 75 years old who fall and break their hip die within a year. Some really high number like that. So, if we can prevent those falls and minimize the risk and improve people's independence, that's changing lives right there in a big way. Did I answer all your questions, Adrian?
You did, with flying colors. Thank you for, I call that one the State of the Union by Daniel Seidler, TelePT Connections 2021.
Yeah. Well, I guess I'll wrap it up since we're on a little time crunch today. And this has been fun. I talked a lot more than I usually do. And I got to say all the things I need to say. Didn't know this was coming, but thanks, Adrian.
Appreciate it, you're welcome. Always here to help my seniors.
What? Okay, I'll take that as I don't know what that is, but I'll say this. We have another guest next week, and it's going to be Eric DeYoung from Trazer, former colleague of mine at, he's still a colleague of mine, but former coworker of mine at Motion PT. Eric is now at Trazer, which provides, I don't even know how to describe it. Do you know what Trazer does, Adrian?
I think it's a kind of motion capture games for rehab.
Awesome. Said it better than I could. And Eric is the COO there, and he's just the man. He's a really smart dude, and he's fun to talk to. It's going to be a great time. So
yeah, I'm looking forward to that. That's, again, kind of a novel type of way to do rehab, and it looks really cool. Yeah, totally. I watched his stuff on LinkedIn. I went to the website and then kind of saw some videos, and so yeah, that'll be a fun one.
And just full disclosure and a little clue into why I'm so excited to talk to Eric is we're partnering with Trazer on this falls prevention program. So I'm sure we'll talk a lot about that next week. So Adrian, have a great week, brother. And see you all next week. Thanks for listening.
Bye.
We hope you learned some things to help you connect with your musculoskeletal system and more. Find us on Twitter at dseidler, that's DSEIDLER, and at Adrian MPT, ADRIAN MPT, and on LinkedIn, Daniel Seidler and Adrian Miranda. We'll connect with you again next time.